Let's walk through this case, which involves a patient presenting with increasing headaches, tinnitus, and right-sided hearing loss, alongside paresthesia in the right facial area, left arm, and both lower limbs. The initial imaging, focusing on the MRI of the brain, shows some concerning findings. We see bilateral lobulated soft tissue masses in the cerebellopontine angles. These lesions appear iso-intense on the T2 weighted sequence, extending along the vestibulocochlear nerves into the enlarged internal acoustic canals. This extension is a crucial detail, as it indicates the involvement of cranial nerves and helps explain the patient's clinical symptoms of hearing loss and tinnitus. On closer inspection, the lesion in the right cerebellopontine angle is relatively large. This mass has significant effects, distorting the right middle cerebellar peduncle and exerting mass effect on the right cerebellar hemisphere. This could easily explain the patient's headache and neurological symptoms, particularly the involvement of facial paresthesia, due to the mass encroaching upon key cranial nerves. Moving further, the axial images reveal a well-defined interhemispheric soft tissue mass in the region of the frontal horns of the lateral ventricles. This mass appears homogeneous and hyperintense to the brain parenchyma, suggesting a benign but space-occupying lesion that is likely causing mild edema in the surrounding white matter, more notably on the right side. This lesion could further be contributing to the patient's neurological symptoms, including paresthesia, as its positioning might affect nearby neural pathways. The imaging also shows multiple irregular soft tissue lesions within the lateral ventricles, with the largest one appearing iso-intense on the T2 weighted sequence. There is also notable dilatation of the posterior horn and body of the right lateral ventricle, indicative of mass effect or possibly obstructive hydrocephalus, secondary to these masses. Shifting focus to the MRI of the spine, multiple well-defined lesions are observed in the cervical and lumbar regions. These lesions are closely related to the nerve roots, appearing hyperintense on STIR and T2 weighted sequences. Enlargement of the neural foramina is another key finding, explaining the patient's sensory symptoms in the limbs. Now, putting together the clinical picture and radiological findings, the constellation of multiple intracranial and spinal lesions, including bilateral vestibular schwannomas, intraventricular meningiomas, and spinal neurofibromas or schwannomas, points us toward a diagnosis of neurofibromatosis type 2, NF2. This is a genetic disorder characterized by the development of multiple tumors, especially schwannomas, meningiomas, and ependymomas. NF2 is a rare autosomal dominant disorder, often resulting from a mutation in the NF2 gene on chromosome 22. It has an incidence of approximately 1 in 37,000 individuals per year. In many cases, about half of the patients have no family history of the disorder, likely due to new mutations. The hallmark feature of NF2 is the presence of bilateral vestibular schwannomas, which fits with the current patient's presentation. Schwannomas are benign tumors that typically arise from the vestibular portion of the 8th cranial nerve, although in about 15% of cases, they can originate from the cochlear portion. These tumors grow within the internal acoustic canal, IAC, extending outwards and causing progressive hearing loss, tinnitus, and balance issues, which we observe in this case. Histologically, schwannomas are usually isodense with brain parenchyma on non-contrast imaging, but they tend to show strong enhancement after contrast administration. Interestingly, in larger tumors, there may be ring-like enhancement due to central necrosis, although calcification is rare. Another key feature of NF2 is the involvement of meningiomas, which can present as intraventricular or interhemispheric lesions, as seen in this case. These tumors can exert mass effects on surrounding brain structures, leading to a variety of neurological deficits, depending on their location. In the spinal cord, NF2 can present with schwannomas or ependymomas, which may cause neural foraminal enlargement and compressive symptoms along the nerve roots. The involvement of the cauda equina in this case, with expansion of the conus medullaris, is typical of ependymomas in NF2. For management, the first step is referral to a neurology team, followed by genetic counseling and family surveillance for screening, as NF2 is a hereditary disorder. Contrast-enhanced MRI is crucial for detecting smaller schwannomas, particularly in the spine and along nerve roots. Long-term management often involves close monitoring and surgical intervention when tumors cause significant symptoms or grow rapidly. In many cases, surgical removal or debulking of vestibular schwannomas is indicated, but care must be taken to preserve as much neural function as possible, especially hearing. In terms of diagnostic criteria for NF2, the presence of bilateral vestibular schwannomas is a key indicator. Alternatively, if a patient has a first-degree relative with NF2 and one vestibular schwannoma, or two of the following: meningioma, schwannoma, glioma, neurofibroma, posterior lens opacity, or cerebral calcification, the diagnosis can be made. Moreover, having two of these tumors without a family history can also be considered diagnostic. The prognosis of NF2 largely depends on the tumor burden and the complications arising from tumor growth. Early detection and intervention, especially for vestibular schwannomas, are crucial in preventing significant morbidity, including hearing loss and neurological deficits. So in summary, this patient's extensive imaging findings paired with their clinical presentation are classic for neurofibromatosis type 2. The key features on MRI, including bilateral vestibular schwannomas, intraventricular and interhemispheric meningiomas, and spinal nerve root tumors, lead us to this diagnosis. Prompt neurology referral and continued surveillance will be critical in managing this patient's condition. If you enjoyed this discussion and want to dive deeper into more fascinating radiology cases, make sure to subscribe to our channel, Radiology Made Easy. Don't forget to comment your thoughts and share this video with fellow radiology enthusiasts or anyone who might benefit from these insights. Your support helps us continue bringing you engaging and educational content.